I proudly would like to introduce the short summary of the professional career so far of Dr. Kata Illés, who graduated from Semmelweis University in 2020 with a degree in medicine. And during her student years, she spent a few months abroad in Italy and Greece as visiting fellow in different clinics as well. And she already took part in the scientific life of the Semmelweis University on the clinics for otorhinolaryngology and head and neck surgery. And her topic was speech improvement after cochlear implantation in non-typical cases. And besides this, because she had a lot of energy, she became also a co-worker in the university library as well. And after getting the diploma, she went abroad again as a fellow to Finland to visit an ENT clinic again. And when she returned in 2021, she started her career as a resident doctor at our department of otorhinolaryngology and head and neck surgery at Wojciech Hospital. And thanks God, she still works there. And again, she has a lot of energy. So she started a PhD work parallel to her clinical work as well. And she started this work at the Translational Medicine Center here at Semmelweis University. And now she will present her results, which are based on two international accepted and well-known journal articles. One was published in a D1 and the other one in a Q1 journal. And besides this, she was also a co-author of four other articles. Two of them is in Hungarian and the two other, again, international articles. And she attended many conferences and congresses here in Hungary as well and also abroad, where she presented her results with a great success. Thank you.
May I ask the candidates, please show your results and your defense material.
Thank you, and welcome everyone. Dear community members, dear professors and friends, I am honored to present my PhD thesis about improving the success in the surgery of chronic medullary disease. My vision is that clinicians use the most effective therapeutic options in the field of medullary surgery, and to achieve my goal, my mission is investigate these options and create high level of evidence. In the last few years, I was lucky to participate in projects which resulted in publications, and two of them are the subject of this thesis. Namely, one is about mastoid obliteration, and the second one is the predictive factors of the tympanic membrane reconstructions. So first of all, the mastoid obliteration is a treatment of cholesteatoma disease. Its incidence in adults in 9 to 12 per thousand population, and in children it's 3 to 15. It usually originates from the tympanic membrane in a retraction packet form, and while it grows, it destroys the surrounding bone structures, and it led to severe complications. Its treatment is surgical, and its recurrence rate in the best centers could be 5 or 35%. And as I mentioned, the treatment is surgical, and one treatment method called canal wall-up technique. This aims to eradicate the disease while drilling the mastoid cavity and keep the external auditory wall intact. However, the mastoid obliteration is an additional technique, so we filled the drilled out mastoid cavity with obliteration material to reduce the size of the mastoid cavity. And nowadays it's became more popular technique because it has been hypothesized that the mastoid obliteration could reduce the recurrent and residual disease rate. And it's important and good for the patients. It could give better quality of life, it saves time, money and resources, and it could decrease the number of reoperations. So our aim was to analyze the available data from the literature to assess the effectiveness of the mastoid obliteration. To do so, we choose the methodology of systematic review and meta-analysis. And here, this slide, you can see our clinical question, which was, what is the effectiveness of the mastoid obliteration compared to the canal wall-up technique? And you can see the PICO framework, where the P is the patient who underwent cholesteatoma surgery, E is the intervention, the mastoid obliteration, C is the comparator group, the canal wall-up technique without obliteration, obliteration, and our primary outcomes were the recurrent disease proportion and residual disease proportion. Secondary outcomes were the hearing results, quality of life, complication rates, and operation time. We conducted a systematic search in 4 databases with this search key, and in the beginning we have 4,700 articles, and from that we found 11 articles eligible to inclusion. Here you can see our most important results about recurrent and residual disease. In the left side, you can see the articles favoring the mastoid obliteration, and the right side favoring the canal wall-up technique. The odds ratio is 0.45 with a low p-value, so that analysis says to us that the mastoid obliteration reduces the recurrent and residual disease rates. We conducted another analysis on 2 subgroups, which were based on materials. The material one was the obliteration material, bone and bone replacement material, and the second one was exclusively muscle or muscle with bone. We didn't detect any subgroup differences with the chi-square analysis. And here you can see the qualitative synthesis on the secondary outcome about the hearing result, complication rates, and quality of life, where we didn't find any clinically relevant or significant difference. However, one article stated the mastoid obliteration elongates the operation time with 1.6 times. As a part of a meta-analysis, we conducted a quality assessment, a risk of bias based on a Cochrane recommendation. We used the Robbins eye tool. According to this, most of the articles was at serious risk due to the confoundings. And in summary, we assessed more than 2,000 operations data, and we used rigorous and thorough methodology. However, these articles were only retrospective cohort studies, and there was a huge heterogeneity regarding the material used for obliteration and surgical technique, and with high risk of bias. Therefore, we could say the mastoid obliteration seems to be a good technique, and in the routinely applied mastoid obliteration is a good surgical option. However, further randomized control trials needed to confirm our results. Our study was published in 2022 in the Laryngoscope Journal. It's a D1 journal. So let's talk about my second topic, which was the reconstruction of the tympanic membrane. The tympanic membrane perforation is a more common disease. Based on US data, is around 2% of the population. And the treatment in this case also surgical, and its success rate is usually around 70–80%. However, the range is quite wide. It could be 40 or even 90%. And why is that? Because there are various influencing factors impacting on the outcome. And to know these factors is essential for many reasons. For example, it enhances the precise patient education. It helps to the preoperative patient care, and it could be helpful to select the proper surgical approach. Here you can see our clinical question again, and we choose the for methodology, the systematic review and meta-analysis. Our clinical question was, what are the predictive factors of tympanic membrane reconstruction? And here you can see the PECO framework, because this is a predictive factor question. So the P is the patients who underwent tympanic membrane reconstruction surgery. E is the exposure, the group of patients with the suspected factors. C is the comparator group, the group of patients without these factors. And the main outcome was the success rate, which is the number of the fully closed tympanic membrane expressed as a percentage after minimum 12 months after the surgery. And the secondary outcome was the hearing results. We conducted a systematic search in 4 databases, and in the beginning we have more than 15,000 articles, and from that 39 was eligible to include. Here you can see we conducted 12 analyses on these various factors, and because lack of the time I cannot show all of them for you. However, I highlighted the significant ones, which was the age, the size of the perforation, the opposite ear status, it was diseased or not, and interestingly, the surgeon experience, resident or senior. Also interesting, there are some results about the site of the perforation and the smoking status, which were not significant. However, the odds ratio was quite similar to the significant ones. However, there was a difference in confidence interval and p-value. We assessed the quality of these articles with the QUIP's risk of bias tool, and the success rate and the hearing outcome was, the majority of the articles was at low risk. Altogether, we could say we assessed high number of included studies and new clinical aspects were revealed. However, the connection between these factors couldn't be revealed because the lack of individual patient data, we couldn't do multivariate analysis on them. And for implication, the PACRIS, the clinicians should be aware of these factors, and it could help with the decision making. However, further retrospective study needed to reveal the connection between these factors. And this study was also published in 2023 in the European Archives of Otorhinolaryngology, and in the thesis conclusion, it's important to prioritizing the implementation, the newly gained knowledge in the field, because it could help with the decision making and could enhance the surgical success. In the past few years, I was lucky to participate some of prestigious Hungarian and international congresses and conferences where I can present my topics. And last but not least, I would like to thank you all of who helped me to create these studies, and without them I wasn't be here. I am especially feel thankful for my supervisor, Tamás Horváth, and the institutional help from the Translational Medicine Center and the Bajcsy Zsilinszky Hospital, and my dear colleagues. And also thank you for my co-investigators and advisors and family and friends. Thank you so much for your kind attention.
So thank you so much also for keeping the time that well. So we have much more time to sweat you and with the questions. We will hear first the two opponents, but before that, actually, can we go to your first selection slide? Because there are many people in the audience that who made the first one. Okay.
Yeah.
The first selection. When you have this chart that you start, like this one.
Yeah.
So, can you explain a little bit for those that who are not familiar with translational medicine, that how is that you found actually 4,700 articles, and only 11 of those could be useful actually for a quantitative analysis?
Because the selection should be very wide. We use this search key for do so, and you can see it's very long, and it's included everything we could available from the data set. And actually, beside that search, we used a very rigorous inclusion criteria. So we went through these articles first with title and abstract, then we read all of the articles which were included the previous selections. And yeah, it should be done this way. So in the beginning, you should start with a lot of articles and find out that one you needed, and not just from the first page from the PubMed.
But that also teaches us that, I mean, that how narrow is the range, actually, but you can get what really highly valuable papers. And this is what we also try to teach, and actually that how to do good research in the future. Okay, so maybe I can ask first Professor Luiber for their questions and notes.
Thank you very much for presentation, and first of all, let me congratulate you for your work. I would like to ask, in your analysis, did you check, or was there any issue about what type of materials they used for obliteration? Was it a criteria that whether they used the bone pate or any artificial materials or glass, biologic glass and so on? That would be my first question. Maybe you can answer, and then I ask one more.
Thank you for the question. So we didn't set any recommendations and didn't exclude any articles based on this matter, so included everything, and then we created this subgroup analysis, and there was no problem with these materials. Actually, you can say the difference in between the ages and publication dates of this data. So the older publication used bone or a mixed material, and the newer one now using bone pate or artificial ones. And actually there is a meta-analysis on this matter, and they compared the bone, autological harvested bone, to the synthetic ones, and they didn't find any difference.
Yeah, because I think it does matter what you use. And I saw that you analyzed the one which are canal wall up techniques, and you do the obliteration. But obviously, if canal wall up and canal wall down surgeries you do, obviously what I see that the combination of obliteration is the combination of the both. So you try to get the advantages of canal wall up and canal wall down together, and take out the disadvantages of these two techniques, which is, I think, if you do a canal wall down and then you do an obliteration, so you build up everything, then you would get all the advantages of the two type of surgeries. But in your analysis, you just analyzed, as I see, the canal wall up ones, and then you obliterated it, yes? Is it right? So canal wall downs were not included in this?
No, they were included.
Because so on your questions, I only saw canal wall ups.
Here we compared to the canal wall ups, but the obliteration was mixed. So we did a subgroup analysis on that well. Here, the obliteration material, the obliteration was done after canal wall up, or done reconstruction, or canal wall down. And later we did a subgroup analysis on separating these, and we didn't detect any differences as well. But here also, when we did analysis on the material, we didn't find any differences. However, in this case, the groups, the number of the included patients in this particular separation ended less patients, so the significant rate might drop due to that.
Mm-hmm. Because when I saw your search criteria, I didn't see that canal wall downs were.
Oh, no.
What was it?
Yeah, yeah. So canal
wall on that
and after the end. Mm-hmm. So the comparator group was canal wall up singly, and we compared everything to that. Mm-hmm. So like, yeah, but there is another meta-analysis where they compare to canal wall down plus obliteration, and canal wall down to canal wall up plus canal wall up versus canal wall down plus obliteration. So, and they have also interesting outcomes, where they found that the canal wall up versus canal wall down obliteration wasn't decreased the recurrent rate. However, it increased, there was a similar rate of the side effects, so the ear discharge and so on, obligations. And when they compared to canal wall down versus canal wall down plus obliteration, it was oh, sorry, it was a bit complicating. So yes, canal wall down to canal wall down obliteration, there was increased risk of, decreased risk of recurrency.
Yeah, I would like to emphasize that the work like what you do, like with this meta-analysis, is very important to bring science to the real world. Because I know that the combination of these two techniques and with the obliteration, in my experience, does really help the patients. And I think, I don't know if you have the same experience at your own institutions, that probably since your meta-analysis or your work, you are doing this technique probably. Have you seen any improvement in your outcomes in respect of complications and recurrence and so on? Obviously, it's not a big time frame, but still you can.
Actually, we started before my publication, and we have data. And actually, we found that it's beneficial for the patient, and we've seen a decreasement of residual disease. And we are constantly working on to assess our previous data and find out how can we be better. And that was one part of the job, to analyze systematically the other publications, and we are actually analyzing our data in the hospital.
And one more question before I hand over. I hope I don't take for the second part. I saw that you had significant the age, the size, the contralateral ear, and the surgical experience. It was significant in your analysis. Have you checked the materials that they use for the myringoplasties or tympanoplasties? Was it checked and it was not significant? It's a bit, for me, it's a bit strange that it means that any materials you use, it's good.
Well, yeah,
in the outcome.
It's a very good question. So this is, these factors were patient-related factors, and these should be investigate one type of surgery. However, we cannot have all of the individual patient data, and it was a little bit mixed with the techniques, but majority of these articles included type 1 underlay tympanoplasty with fascia. So these results became from that. However, we analyzed some meningoplasties and fat graft meningoplasty and paper graft separately in the quality analysis. Yep.
So congratulate for you. It's a huge and nice work.
Thank you.
I have some question too. First, for the second part of your work, why did you not research the different type of the incision, for example, endaural, retroauricular, or transcanal, and endoscopic possibilities, surgical options for the type 1 tympanoplasty?
Okay, thank you for the question. And it's like the same. So we are investigating the patient-related factors, not if we wanted to answer this question, which incision, which technique is the best. It's a different kind of question. It's not a prognostic study that it should be answered with a trial. So we just wanted to know these factors, because these factors are important even in a trial, to make it randomized. And as I previously said, the majority of the articles was used the traditional underlay fascia method, but sometimes there was some methods mixed with that. However, we cannot exclude because they didn't provide us the individual patient data.
Thank you. And my second question for the first part of your work. What do you think, what is the reason why you found significant benefit in mastoid obliteration when you looked at cholesteatoma recurrence and residual disease together? But otherwise, when you looked at them separately, you cannot find significant difference for either recurrence or the other, it's a remain disease?
Yeah, thank you for the question. It's very, very important. So the odds ratio was quite similar on those cases. So it seems the tendency it reduces the risk of recurrence in residual disease. However, in those analyses, the number of included patients was dropped drastically, so like half it. Then the power of the analysis was much more less. Then it wasn't statistically significant. However, we see the trends, and it's the analysis trends tell us there is something we should more thoroughly investigate.
Thank you.
Meanwhile, you are thinking about questions. I would like to ask your opinion and maybe your group's opinion. That why do you think that if someone does a canal wall up tympanoplasty and afterwards you obliterate with any materials the mastoid, why do you think it's scientifically or in real life, why do you think it stops or reduces the recurrence rate? What can be the explanation behind that? Have you think about that?
Yes, there are some publications try to answer these questions. However, we don't know it yet for sure. It actually might change the ventilation profile, and as well it might create an environment for the residual disease to not stay alive there. And there are actually one animal data said that, but still we don't know.
Congratulations, excellent presentation. I had a question about your first project. So your subgroup analysis showed that there's no difference between material 1 and material 2. Does that mean you would suggest using any of them, or is material 2 part of the past? No.
Thank you so much for this question. Yeah, actually, if we cannot detect, that's not means there is no effect. So, as I mentioned, if we separate these articles and try to analyze more the number of the patients included much less, and the other one is like these are not randomized control trials. So if we want to investigate one differences, we should do a trial on that, and we try to make that difference. However, there are other confounding factors might overlap, so we don't know. So one analysis that say it's not significant or we cannot detect, and it's based on the data of not randomized trials. You should be always skeptical. And there are some data like the muscle tend to be shrank over time, and there are other data on the bone and bone dust. It remains on the mastoid cavity. And these articles have a follow-up, mean follow-up time is usually around 30 months. And it would be very interesting to see the longer follow-up, because we know the cholesteatoma disease could even appear after a decade.
So you mentioned that you had only retrospective cohort studies in your first project. Do you have maybe an idea what the reason for this is?
Yes. This field is very hard to make randomized control trials in a surgical field, and usually the doctors who operate on ears, they have their preferred method and use that, and it's very hard to find someone who are comfortable to doing different things all in the same time.
And what would be your main research implications for those who would incentivize to create such an RCT?
So my implication would be like they try to compare the canal wall up to the canal wall up with obliteration, then compare the canal wall down to canal wall down to obliteration, because that's much more similar. And actually, they should be extend the follow-up time as well.
Thank you.
All right, I have 2 more questions at least, if no one else, of course. The one is that the length of surgery. I mean, you just mentioned that there was one study actually. I mean, of course, I mean that's better to have shorter surgeries. So is this really kind of that important? And then what is in your hand? Because you just had one paper quoted. So what is your experience at your center? That is this really adds 50% of the time, or that's worth to do anyway?
Yeah, it's a very good question. It's definitely extend the time, because you have to harvest the bone material, and if you are creating a canal wall done surgery, you have to build up the wall again, and it takes times. However, it might be not 1 and 6 times more. So in our case, it's like 20 minutes or half an hour more. But if in that case, if you are extended that surgery, and in later you don't operate that patient again, that's beneficial for all assumption.
Yeah. The other question relates to this somehow, because I mean, you just said that that's very hard to do a randomized clinical trial.
Yeah.
Now you have quite a bit of experience, and then you did all the kind of in silico work. So is there any chance actually to do the proper clinical trial? Do you have plans for this?
Yeah, it's a very nice dream, and I hope I hope it's one. Yeah, we would like. Actually, I would like to do, but it's recommend a lot of work, and you need other people who helps you, the statistician, the nurses, secretary who helps to register the patients, and you actually need a more center to do that, because as I mentioned, this disease is quite rare. So you have to work together with lots of people, and it's recommend lots of energy, and yeah, maybe one time.
Yeah, I would just encourage all of you, I mean, to go towards that direction. More questions? Everybody is exhausted and satisfied, and then air, we don't have enough air, maybe. Well, if not, then this was your defense. So this is the announcement of the final score, which is 100% maximum score. Congratulations. Keep going. So I was the chairman, so I can congratulate first. Okay, to you.